Okay. Dr. Rizk, as long as you're ready, I'm just going to briefly introduce you. So Dr. Rizk, some of us who know and love, is associate professor here at MUSC in the Department of ENT. He's also the director of the multidisciplinary vestibular program that we have here. He is currently on the board of directors and is the vice president of the Vestibular Disorders Association. So he is our resident expert as well as sort of a national expert in vestibular disorders. And today we're very lucky to have him on to talk about vestibular migraine, both atypical presentations and a wide variety of differential diagnoses to consider. So thank you so much, Dr. Rizk, for coming.
Thank you, Erin, for inviting me. I like this specific lecture because, the amount of things that we encounter every day, of patients we encounter every day that present with common ENT and otologic complaints that could also be explained by vestibular migraine is staggering. And I hope this lecture will push you as residents, as fellows, as new practicing attendings to think about that when you're encountering a patient where traditional things are not working. These are my disclosures. The objectives of the talk is to recognize atypical ENT presentation of migraine disorders and to differentiate vestibular migraine from other central vestibular disorders. First, a quick look at the Berenice Society in 2009 tried to classify the vestibular symptomatology into four broad symptom labels. One is internal vertigo, a sense of illusion of movement of oneself, which can be spontaneous, spinning or non-spinning, as well as triggered. Then they chose the word dizziness as defined as a sensation of spatial disorientation. I'm not sure why my slideshow is advancing on its own, but you'll see me toggling back and forth. A sense of spatial disorientation that they call dizziness that can be spontaneous or triggered. Vestibular visual symptoms, which include the external vertigo as we recognize it in BPPV and neuronitis, but also includes oscillopsia, which is the sense of movement of the environment with or without head movement. So oscillopsia with head movement is a hallmark presentation of bilateral vestibular hypofunction. Without head movement can be due to a spontaneous nystagmus, like a downbeat nystagmus that is very intense. Visual lag and movement-induced blur are typical symptoms in line with a deficiency of the vestibular ocular reflex. So a hypofunction that, a neuronitis has resolved, but then you have a hypofunction that is underlying that. They can present with visual lag and movement-induced blur. And finally, visual tilt, which is a typical otolytic symptom coming from the utricle and saccule, where there's a sense of the tilting of the room. It can be peripheral, but also it can be encountered with vestibular migraine, which is known to affect the otolytic pathways or thought to affect the central otolytic pathways. And finally, postural instability, which includes unsteadiness, near falls or falls, as well as directional pulsion, which is another word for drop attacks. If we look at the time course of symptoms of the various vestibular disorders, we can see, for example, and these graphs are a courtesy of Michael Teixeira, who has an excellent presentation about vestibular migraine at the Academy for those of you who are attending, and I strongly recommend it. So vestibular neuronitis presents with a high intensity of symptoms that quickly tapers down and then slowly goes back to baseline. BPPV is very short, intense intervals that come in clusters and slowly decrease in intensity. Vestibular neuronitis with secondary BPPV, which is about 40% of neuronitis, presents with this, type of visual representation of the episodes. Meniere's disease is paroxystic episodes with sometimes not a clear-cut patterns to them. And then you have vestibular migraine, which can be all of those type of presentations. The Vestibular Disorder Association tried to do a triage protocol, mostly geared toward the primary care physicians. And while it is a very good and well-done triage protocol that allows the PCP to know when to send patients to the emergency room or do an acute assessment for a stroke or a cardiovascular involvement, when we look more closely, vestibular migraine is listed under that fourth column, counting from the left, but it can actually fit in most of those, depictions that we have on this graph. Also, vestibular migraine can be a comorbidity of various of those things. You can have BPPV with vestibular migraine. You can have it with Meniere's disease or with hypofunction. So keeping a broad differential and making sure we're not missing one other vestibular morbidity is extremely important. A study done at with the CHEER network a few years ago now looked at where do migraine sufferers seek medical care. 2/3 at the primary care physician, 16% at the neurologist, and 17% is other, which includes ENT. So the CHEER network used this migraine assessment tool and looked at patients presenting to various academic and private practice ENT across the country with various otolaryngological complaints. And they administered that migraine assessment tool. And they found that 16% of patients, of ENT patients, have migraine. So these are patients presenting even for a GERD. And they were trying to see the prevalence of migraine within the ENT population. And 28% of those ENT patients have chronic migraine. And then they also looked at the correlation between dizziness symptoms in those patients who scored highly on the MAT, the migraine assessment tool, and sinus symptoms. And they found a high correlation between sinus symptoms and dizziness. It doesn't mean that we're talking about sinusitis here, but sinus pressure is a common complaint of migraineurs with the absence of sinus disease. So there's a high correlation of those atypical symptoms in those patients. And then when they looked at the vestibular symptoms themselves, lightheadedness topped the chart. About 2/3 of patients had it. 50% had an unsteadiness. 1/3 of those patients had a spinning sensation. They didn't specify in the study whether it's an internal or external vertigo. 30% had a feeling of displacement in space, and 24% had rocking or swaying. They also had a high prevalence of oral pressure, fullness in the ear, tinnitus, a foreign body sensation in the throat and in the ear, and a burning tongue syndrome. And they also had a wide distribution of that sinus pressure that could exactly mimic what a sinusitis would look like. So the first atypical presentation that I want to talk about is motion modulated oscillatory vertigo. That's the Bernie term for chronic rocking dizziness. It's highly associated with migraine. Mulder-Barkman syndrome is a form of it. It's uniquely responsive to PT, a specific PT. There's multiple protocols that have been developed. One of them is optokinetic retraining at Mount Sinai in New York. But in our practice, our physical therapist uses grounding strategies, we call them, to try to increase the weighting of proprioceptive input on the brain's response to balance. They respond to concurrent migraine management. And an unpublished study that we did looking at our chronic rocking dizziness population looked at those patients who had PT alone, medication alone, or a combination of both. And medication, we usually use either an SNRI like venlafaxine or clonazepam, much more rarely. And we looked at the DHI, and the DHI dropped about 30 points when we combined the medication with PT. Dropped about 20 points when we used each of the PT and medications alone. And a minimum clinical important difference with DHI is about 18 points. So there's something to be said. When you can, I usually try to add medication for this. And to summarize what the types of motion modulated oscillatory vertigo, there's 3 types that we can recognize. Mulder-Barkman is one. Persistent postural perceptual dizziness is a second one. And non-motion triggered, so contrary to the Mulder-Barkman, it's not triggered by a passive motion exposure. And potentially that middle one, where the people developed a spontaneous type of Mulder-Barkman, this is the type of patients we see a high comorbidity of migraine with. About 90% either have a migraine or will develop a type of headache syndrome following it. And you'll see those patients at that point in time. And targeting the headaches is going to be important, as well as referring them to PT appropriately. So always consider migraine as a pathology and as a treatment path when patients present with chronic rocking dizziness. Now, the second atypical presentation is otalgia, ear pain. As I showed you earlier, about 40% of patients that scored positive on the migraine assessment tool had oral fullness as part of their symptoms. In 2011, this paper was published in Otology Neuro-Otology and looked at 48 patients who presented with otalgia, had negative exam and imaging, had a history of migraine headaches, and had failed every other treatment, including laryngotomy tubes, trial of PPIs, TMJ dysfunction management, and they were offered migraine treatment. 90% of them responded to the migraine treatment, and 42% of those patients did not have a bona fide ear pain like you would see in a neuralgia. They had just an ear fullness and an ear pressure. And a third of them had head and sinus pressure. 23% had migrainous vertigo. And that paper was published a year before the Bereni criteria for vestibular migraine came out. But at the time, we had not settled on the consensus of using vestibular migraine as the label. So migrainous vertigo refers to vestibular migraine. So 23% of patients who had this unexplained ear pain had a vestibular migraine underneath, which we will see later how much it can make the differential diagnosis with Meniere's disease sometimes difficult. And if you look at some of the criteria they looked at concerning that otalgia, they had a lot of triggers that are similar to the triggers we see in migraine. So an unexplained ear pain, after ruling out eustachian tube dysfunction and TMJ, you have to I strongly recommend considering migraine treatment. Of course, after ruling out any type of referred ear pain, and getting an imaging if you want to get even more, comfortable. If you make sure you're not missing anything. So, which brings us now to the migraine and Meniere's disease correlation. Meniere's disease criteria evolved a little bit between 1995 and 2020. In 2015, the Bereni criteria were published and simplified a little bit the criteria into definite and probable. In the 1995 criteria, we had certain, definite, probable, possible, kind of like it's almost impossible to remember and categorize adequately sometimes. Definite, you need to have 2 spontaneous episodes of vertigo lasting 20 minutes up to 12 hours, with an audiogram showing a low to medium frequency hearing loss in at least one ear. And they were very strict about the amount of hearing loss you can have. So a 25 dB asymmetric hearing loss on one side would not qualify per the Bereni criteria. Obviously, clinically speaking, sometimes patients fall in those gray areas and you need to use your clinical discernment to categorize them. But from a research purpose, they were very strict about having at least a 30 dB hearing loss worsening in the affected ear compared to the opposite ear. Or if both ears were affected, you need to have a hearing loss of more than 35 dB. They have to have a fluctuating oral symptom, hearing, tinnitus, or fullness in the affected ear or ears. And those symptoms have to occur within 24 hours of the vertigo episode, not completely at random. And in 2020, the AAO took over those criteria, simplified them a little bit, and they decided that the audiogram has to be positive on at least one occasion before, during, or after one of the episodes of vertigo. Whereas the vestibular migraine criteria, published in 2012, they're listed here. You have to have 5 episodes of vestibular symptoms. So the initial slide that I talked about, internal vertigo, vestibular visual symptoms, dizziness as a spatial disorientation. Those are and postural instability. Those are vestibular symptoms of moderate to severe intensity lasting 5 minutes to 72 hours with a current or previous history of migraine with or without aura, and 1 or more migraine features with at least half of the episodes. Not everybody needs to have a headache with their episodes to qualify for the diagnosis. And the Bereni criteria and the International Classification of Headache Disorders acknowledge that there's an overlap with Meniere's disease. And that's very important because this was published, that edition of the ICHD classification was published in 2013. And they said, at this point, whenever the criteria for Meniere's disease are met, that's when you should follow a Meniere's disease treatment path, unless the patient is describing 2 distinct types of episodes. One that fulfill criteria for Meniere's and one that fulfill criteria for vestibular migraine, which is, in my clinical experience, in my population, is about 10% of patients have that true overlap. And that correlation with migraine has been present since Meniere's disease was even first introduced as a pathology by Prosper Meniere, who noticed that all of those patients he had that he was presenting at the French Academy of Medicine actually had a migraine. Now, the lifetime prevalence of migraine in patients with Meniere's disease is about 56% compared with 25% in controls. That's based on a seminal paper from 2002 by the Berlin Otologic Group. Meniere's attacks are accompanied by at least one migraine symptoms in 45% of patients always, and only sometimes in 11% of patients. It's unlikely that this is a coincidence, and maybe there is a causal link between Meniere's disease and migraine. Many patients are in the gray area in between Meniere's disease and migraine. But when we look at the actual physiology of the inner ear, we see that the inner ear, despite it being this small, privileged space where very few reactions, systemic reactions may occur, actually has a very solid density of receptors, ion receptors, electrolyte receptors, as well as receptors for steroids and beta-adrenergic receptors. And this also explains why some patients with Meniere's disease may improve with migraine management, because a lot of those off-label migraine treatments that have been historically used are sodium channel blockers or GABAergic blockers or beta blockers. So again, the correlation between Meniere's and migraine also extends to how migraine treatment can affect Meniere's disease. In 2017, the Meniere's disease consortium in Europe published on the Meniere's disease endophenotypes. They looked in a multi-institutional way across Europe about several hundred Meniere's disease patients, and were able to do a cluster analysis and identify 5 clusters. One is type 1 classic Meniere's disease, fulfills all the criteria. There's no correlation or overlap with other pathologies. Type 2 is delayed Meniere's disease following a surgery or a trauma to the ear. Type 3 is familial, with a confirmed first-degree family member who has a confirmed Meniere's disease. Type 4 is a comorbid migraine disorder, whether it's headache, vestibular migraine. It's not necessarily vestibular migraine, so any type of migraine disorder that comes in that patient. And type 5 autoimmunity. And you see how familial migraine and type 5 autoimmune, the cluster can overlap. And more recently, earlier this year, the same group published a paper on vestibular migraine endophenotypes, where 5 clusters were identified. One that had a longer duration of vertigo attack. Another one, 21% of the patients reviewed had absence of migraine headaches and cochlear symptoms. So they fulfilled the Bereni criteria based on the other criteria, photophobia, phonophobia, visual aura. 18% of patients had cochlear symptoms, including fullness, tinnitus, and subjective hearing loss during their vertigo attack. And 23% had presence of cochlear symptoms and migraine headaches during their vertigo attack. And they had excluded from their population anybody who had a low-frequency hearing loss. So about 41% of patients with vestibular migraine, as we currently recognize it in the Bereni Society criteria, had present otologic symptoms during their attacks. And finally, 27.9% had migraine headaches and no cochlear symptom during the vertigo spell. The authors here speculate that there might be multiple types of pathways in which the vestibular migraine can cause a vestibular symptom. In the long duration of attacks, and the last one, the migraine headaches but no cochlear symptoms, it's probably a central process. And the ones in the middle where there is cochlear symptoms, it's probably a vasospasm of the internal auditory artery, which leads to peripheral manifestations and a Meniere's type pathology. So a lot of groups are working very hard to differentiate the 2 pathologies. The MRI high drops can be used sometimes with good, the high drop protocol can show a high drops in over 90% of Meniere's disease patients that fulfill criteria for Meniere's disease. It can show it in vestibular migraine and in other pathologies, but at a lesser prevalence. In my clinic, I sometimes use the MRI high drops to guide my treatment when I have absolutely no way to check the boxes of Meniere's or check the boxes of vestibular migraine. And if there's a significant high drops, I follow a Meniere's strategy. If there's a mild or no high drops in the suspected ear where there's a lot of cochlear symptoms, I follow a migraine strategy. But there's also been a lot of studies on, or a few studies on pro-inflammatory markers, including with our group and with one forthcoming publication. And there's a bit of differentiation with some of those inflammatory markers. IL-1 beta seems to be a differentiating marker, but it's extremely difficult to detect. It comes in picograms, and so that one is much more difficult to confirm veracity of. There's other chemokines that can be more elevated in one disease or the other. Andrea Van Butis from New York published recently on a study showing the IL-1 beta higher prevalence in Meniere's disease, but also TNF alpha, which is similar to what we see in AIED patients. And in our group, when we looked at 20 definite Meniere's disease, 20 definite vestibular migraine, and 10 healthy controls with unstimulated peripheral blood mononuclear cells, we had higher levels of TNF alpha and interferon gamma levels, and reduced levels of ENA 78, which is a chemokine implicated in the eosinophil pathway, which also lends credence to the correlation between eosinophils, allergy, and Meniere's disease. TNF alpha seems to be a recurrent or redundant marker that from various studies, as well as IL-1 beta. So when migraine or vestibular migraine and Meniere's disease co-occur, it's important to treat both. And I made a mistake that I usually tell residents to stop using. Migrainous vertigo, we should stop using it. We should use the word vestibular migraine. So I'm sorry for that typo in my slide. It's especially important to address migraine before proceeding to any ablative therapy for Meniere's disease. I would never inject gentamicin in a Meniere's patients before trying a migraine drug. I would say, 99% of the cases at least. Many patients with Meniere's disease will find that their attacks are triggered by some of the typical foods that trigger migraine. So I always put both patients on both diets. They are complementary diets. And always consider that otologic symptoms can be due to the migraine process. So if somebody has very well controlled vestibular symptoms, but has fluctuating tinnitus, hypercusis, oral fullness, I always consider a migraine treatment and discuss it with the patient. So from there, let's talk about drop attacks and dysautonomia. So drop attacks or Tumarkin crisis are a severe manifestation of Meniere's disease related to a sudden fluctuation of pressure around the utricular or saccular membrane. And I always put this slide with the actual clinical vignette description from the original article in 1936, because it's really very accurate. Having witnessed one in one of my patients, that's more than I would care to witness in clinic. It is a very dramatic loss of vestibular spinal reflex and loss of tone of all the truncal muscles, and patients basically collapse to the ground without losing consciousness. So Mr. X was standing at his desk talking to a client when suddenly he slumped to the floor. He had no vertigo, no loss of consciousness, and no malaise. The thing came like a bolt from the blue, but he was immediately able to assure onlookers he was all right. A saccular drop attack, this guy was standing in his van receiving packages when suddenly he felt as if the wheel had collapsed under him. He crashed down on his side. These are patients who feel like they're being pulled or shoved to one side. They have what we call a lateral pulsion. Lateral pulsion can happen in certain brainstem strokes, but in the setting of Meniere's disease, it can also happen. It can also happen in the setting following an Epley maneuver. This is a nice video from the Jacobson and Shepard book. And I'll show you. This lady had an Epley repositioning, and as she was sat up after the 3 maneuvers of the Epley, the otoliths basically entered the vestibule very quickly, and then suddenly there was a fluctuation of pressure along the utricular membrane that led to this, what you just saw here, a sudden collapse to the side or to backwards. So I would never do an Epley in clinic and walk away from a patient. It can happen after a few seconds, and you need to be able to catch them. And it's always difficult to differentiate a drop attack from a syncope. So you have to really dig in the history to make sure you're capturing that. And while somebody presenting with loss of consciousness, you have to always rule out a cardiovascular or hemodynamic cause. The patients who are ending up in your clinic after they have already seen the cardiologist. They've already almost always had a heart monitor and a cath and all of the cardiac workup. But there is something that is being more and more recognized, which is the term vestibular syncope. The vestibular system can affect the cardiovascular system pretty intensely. And the vestibular sympathetic reflex is the first reflex to be engaged when we change positions, even faster than the baroreceptor reflex. So the way to understand vestibular syncope is a type of dysautonomia, a dyssynergy between the vestibular sympathetic reflex and the baroreceptor reflex. Let's take a normal subject sitting down. They go to stand up. The vestibular sympathetic reflex is stimulated by the change of the gravity vector. It immediately detects that the body is not in the same plane that it was in, and the blood pressure and heart rate go up. Because there was an actual orthostatic change, the blood flow will go down. So the baroreceptor reflex is engaged in an opposite direction. Because the blood flow had went down, the baroreceptor reflexes are less stretched, and they will engage the sympathetic system even more, and you will have a blood pressure and a heart rate that increase. And those are the patients who don't get any syncope or anything when they change positions. Now, take the example of a patient with vestibular migraine or Meniere's disease, and they have a vertigo attack, and they're sitting down. There's no orthostatic change. The brain interprets this similar to when we stood up. There's a shift of movement compared to the initial gravity vector, which engages the vestibular sympathetic system, and you have a high blood pressure and a high heart rate. But this time, since the blood flow doesn't go down, the high blood pressure and high heart rate will distend the baroreceptor and engage the baroreceptor reflex to stimulate the parasympathetic reflex, and you will have collapse of the blood pressure and lowering of the heart rate following an initial uptick in it. And those are the patients who develop a loss of consciousness or a pre-syncopal event with their attacks. Some studies have reported that 4% of Meniere's patients describe pre-syncope with their Meniere's attack. So drop attacks can occur with migraine and other disorders than Meniere's disease, and syncope is not always due to a hemodynamic cause, but can be due to a vestibular pathology. And I've had patients in the middle of a BPPV attack. They're laying down, their nystagmus is really fast, and I ask them, what are you experiencing right now? And they tell me, I feel like I'm about to pass out. They don't describe spinning. So always have an open mind when somebody says pre-syncope. Of course, rule out a cardiac cause, always be safe, but keep in mind that a vestibular system can trigger those type of symptomatologies as well. Which lead me to talking about otolytic dysfunction, and I'm not going to belabor that point. We've already said that the drop attacks are a utricular or saccular type of symptom. And I said earlier that visual tilt is a symptom that I sometimes see in my vestibular migraine patients, and it's also another otolytic pathway type of symptom. Now, in order to understand the migraine and otolytic disruption, it's interesting to read the literature that is related to microgravity environments. In microgravity or zero gravity, the caloric response doesn't work very well. So the semicircular canals, which relies on convection currents that by definition require gravity because there's a density of fluid related to that, are not working very well. So the vestibular ocular reflex is disturbed in astronauts. They only rely on their otolytic system. And even the otoliths are no longer, the utricle and saccule are no longer providing meaningful information. They only act like accelerometers and only detect linear acceleration. They don't detect the relationship of the head tilt to the Earth is vertical because they don't know which way is up, basically, when you're in 0G. So when astronauts return home, they experience some of those after effects, and the symptoms they describe related to the otolytic organ disruption include difficulty walking around corner, sensation of linear movement or free fall when they tilt their head, sensation of the head being detached from their body. All of those symptoms you will hear a vestibular migraine patients talk about. So basically, a vestibular migraine patient is like a true zero gravity type of model of what could happen in deep space. And those disruptions that are initially functional, when they did experiments on animals and left them in weightlessness for long periods of time, there was a dramatic alteration in the end organs with changes to the peripheral nerve connections to hair cells and sensory adaptations occurring at the level of the inner ear, at the level of the otolith organs and the semicircular canal. So all otolith disruptions can cause a sensation of weightlessness and floating that we observe in our migraine patients. Some of the migraine patients we see with those symptoms, it can be due to some sort of peripheral involvement, or it can be due to the central otolithic pathway being affected. So those patients are not crazy, because I hear that sometimes, and um, there's a stigma related to functional disorder, meaning that it's always a conversion disorder, which is not the case. This is a type of otolithic functional disruption. Those astronauts who come back from zero gravity environments, they have a functional disruption of their system that takes time to readapt and readjust. And our vestibular migraine patients with those symptoms have the same type of presentation. So now that we've seen that migraine can present with otolithic disruption, the next stretch is to talk about BPPV, because the otoliths are housed within the utricle and saccule. There's a higher comorbidity between migraine and BPPV. Migraine is 3 times more frequent than in idiopathic BPPV than in BPPV secondary to head trauma. Migraine is twice as more prevalent in patients with BPPV than in age and sex-matched controls. The odds ratio for BPPV in individuals with migraine is 7.5, so they're 7 times more likely than other patients without migraine to develop BPPV. We also found in our own institutional study that there's a higher prevalence of recurrent BPPV in patients with incidence with migraine and with lower vitamin D levels. So the question is, can migraine cause BPPV? Obviously, we talked about earlier how migraine can cause an otolithic disruption. So it's theoretically, that is possible, that a migraine activity leading to a peripheral alteration, not yet verified. This statement, I would say, is kind of more in the theoretical concept, can lead to the crystals falling out of place. But there's also a new concept that is being discussed more and more, which is the light and heavy cupula. Cupula being the sensory organ neuroepithelium within the semicircular canals. And we'll talk about it in a second. So I'm going to present a quick case about this. It's a 51-year-old patient who presented to my clinic with episodic vertigo for the past 8 years. She had a previous diagnosis of BPPV, treated with Epley. She had an episode of vertigo in December 2020 following the COVID vaccine, then another episode April 2021 following a bike ride, and another episode in July 2021 after a car ride. And when you ask her, her episodes present with spinning sensation when she rolls to the right side of the bed, and they would last minutes at a time. She was sent to me 6 months after that April episode, where continued Epley maneuvers were not clearing her clearly positional symptoms. To make the irony even more palpable, the patient is a vestibular audiologist. Now, she presented with this audiogram that showed a conductive hearing loss. I didn't know what to make of it. Her ear exam looked fine. Sometimes airborne gaps in the low frequencies are seen in superior canal dehiscence. They've been reported in Meniere's disease to have a low frequency airborne gap, but it didn't make sense. She did have a fullness in her right ear with her most recent episodes. And when you dig in further with her symptoms, she describes that her balance is no longer the same since that April attack. She had been off balance for 6 months. She would sometimes note a rocking sensation. She'd feel better when she's moving, feels that she keeps on moving when she stops, like on a traffic light. So she had a motion modulated oscillatory vertigo. She had no tinnitus. She had no phonophobia or photophobia and a history of migraine. Her outside VNG showed a mild positional right beating nystagmus, and in my clinic on exam, when we laid her to the right side, she had a couple of seconds of a right beating torsional geotropic nystagmus, followed by a very low and slow right beating horizontal nystagmus that did not fatigue after several minutes. So she had something that looked like BPPV, but then this very slow horizontal beating nystagmus following it. Which brings us to the light cupula concept. So this we think that about 5% of people who are diagnosed with horizontal BPPV are misdiagnosed. And the problem is not crystals that are mechanically disrupting the endolymph flow, but another mechanism that is causing that. The first theory about what that mechanism could be is a lighter cupula, a change in the cupula density. And we have something that is proven that works, that causes that. It's the positional alcoholic nystagmus. We know that in these conditions, when alcohol is high in the systemic circulation and it diffuses into the cupula, there will be a change of the density of the cupula that leads to a specific nystagmus and symptoms. It could also be that the endolymph becomes heavier due to a labyrinthine bleeding, to inflammation from a CNS infection, sudden sensorineural hearing loss with vertigo. There's a study that showed that those patients had a higher prevalence of direction-changing positional nystagmus. There's a hypothesis that this could be a specific type of debris that increased buoyancy rather than heaviness. And those degrees include swollen inflammatory cells in the endolymph, chemically generated products from the otoconia. And a quick parenthesis, the otoconia have a calcium carbonate core, but there's tons of proteins and other miscellaneous compounds presented within them. And if any of the mechanism that typically cleans the endolymph from the debris of the otoconia is not working, you can have a megalith, or you can have a lot of those compounds floating around, making the endolymph heavier. And finally, two other potential mechanisms include the utricular macula dysfunction, but wouldn't explain the positional type of nystagmus, and a density mismatch between the perilymph and endolymph, exerting pressure across the membranous labyrinth, which is collapsible. So obviously, the first three mechanisms, a light cupula due to a systemic mediator changing the cupula density, a heavier endolymph, or on the opposite, an endolymph debris that is stuck on the cupula from the inside and making it more buoyant. All of those three are the most likely mechanisms in this case, and vestibular migraine can contribute to those findings. First of all, a lot of patients with vestibular migraine have positional nystagmus that is not explained by BPPV on interictal examination. We know that in vestibular migraine, there's a high interaction with the trigeminal pathways, and we know that the inner ear is primarily innervated by the trigeminal vascular system. So if you have an increased excitation of the trigeminal nociceptive pathway, that can lead to downstream metabolic effects on the inner ear that can show us those nystagmuses. Other CNS disorders that can present with light cupula include a brainstem stroke, cerebellar tumors, and HIV encephalopathy. So that patient, I said, okay, she doesn't fulfill criteria for vestibular migraine. This is not BPPV. I'm going to order an MRI, but I'm going to also start her in the meanwhile on venlafaxine 37.5 milligram. I told her to reduce her salt intake. I didn't know what to make of that conductive hearing loss, or I didn't think she had Meniere's, but I told her to reduce her salt intake. And 6 weeks later, she had complete remission of her symptoms, but also her nystagmus was gone after being present for 6 months with symptoms. And her MRI shows a small intravestibular intracanalicular schwannoma to top it all off. So whenever you have a BPPV that is difficult to treat, always screen for a migraine pathology. Always try a migraine treatment. There's almost no harm. Get an MRI, make sure there's nothing else that is weird lurking there. This lady had been followed since 2021. Her schwannoma has not evolved, and she had been symptom-free since we put her on the venlafaxine. She doesn't want to stop it at this point. But so again, in this case, probably the schwannoma was playing a role as well. Now, and I think I'm almost toward the end of my talk. I hope from this talk, I wanted you all to think about migraine that is more than just a headache, which is, despite almost over a decade of having the Berenice criteria for vestibular migraine, I still see, unfortunately, patients who tell me, my ENT does not believe that vestibular migraine exists. Or I get patients who tell me, I don't believe that vestibular migraine exists. It's not a matter of faith. There's a lot of clinical data to confirm that. There's also a lot of clinical data that is pushing us to widen the current definition of vestibular migraine, but to also consider how migraine can influence other systems. there's a push with the Migraine and Otolaryngology Society within the academy for something called sinus migraine. These are the patients with minimal sinus disease and sinus pressure and atypical facial pain. Almost all of them respond to migraine treatment. Cochleovestibular migraine. About 40% of vestibular migraine patients have cochlear symptoms that could mimic Meniere's disease. So always be mindful of that. And finally, cochlear migraine. Sudden sensory neural hearing loss has been correlated to certain migraine pathologies at times. Fluctuating hearing loss, hyperacusis, ear pain. So how can I be sure it's migraine? Maintain a high degree of suspicion in patients with new onset dizziness, motion sickness concurrent with headache activity. Pattern of symptoms not fully explained by your initial diagnostic consideration, BPPV, Meniere's disease, or neuronitis. And also think that it could be grafting itself. It could be multiple comorbidities at the same time. Associated neurological symptoms, sinus headache with vertigo, hemiparesthesia, hemiplegic symptoms without evidence of a stroke. No hearing loss or hearing loss in the high frequencies. Triggerability, association with recent life stress or weather changes. Past history of migraine, a family history of migraine or symptoms similar to what the patient is describing. Perimenopause. And once you have ruled out a stroke or structural central issues, if you have a suspicion, a treatment trial would be the next step. And getting comfortable prescribing those medications is fairly easy. These are medications that you can start at low doses. They have some side effects that you need to be aware of, but most patients are able to tolerate them and have excellent results. This is the end of my talk. I wanted to just put a plug-in for the new ANS Vestibular Disorder Association Clinical Outcomes Research Grant, which is going to go live in the spring, this spring, and it's one of the 3 ANS grants that will support a fellow and young attending looking at a vestibular disorder project. So more details forthcoming from the ANS. And that could be from basic science projects to clinical science projects. Obviously, we need to have something that is able to improve healthcare outcomes. And this is supposed to be funding pilot studies that can go on and get bigger funding afterwards. This is a QR code that lists all the studies that we are doing at MUSC or connected with at MUSC, including patient registries that I encourage patients to fill out. The more data we get, the better informed we will be. And the Migraine and Otolaryngology Society has a free membership. It started as a splinter education study group from the academy, and it has a lot of resources for your educational content and where you can a forum where you can ask questions and get answers. Thank you.
Thank you
Happy
so
to
much.
take any questions.
Well, Dr. Rizk, I actually had a question to kind of start us off. I know the meeting will end shortly and I'm trying to extend it, but when you are interviewing these patients with such, dissimilar to you, but similar to maybe just an ENT or general ENT, what types of vocabulary do you use to help lead the patient during the interview to help them describe what's really going on to them? Yeah.
So the first thing I do is, first of all, I want to hear them use their own words. And sometimes they get frustrated. We said it multiple times. And the patients who have absolutely no vocabulary, which is very frequent, first thing I say, stop using the word vertigo. My definition of vertigo is an illusion of movement. Does that sound like an illusion of movement? Then when they say dizziness, I say my definition of dizziness is a sense of spatial disorientation. You don't know, your head doesn't feel like at the same plane as your body. You don't know where you are in space. Is there a tilt? So sometimes patients have a very precise vocabulary, and sometimes when they don't, I kind of give them the definition of what I'm expecting that word to mean, and you tell me if that fits. And those are the harder patients, obviously. But most of them, it's kind of funny because most of the patients will come as if they've talked to each other. It's this laundry list of symptoms that you've heard many times, and patients, and it doesn't sound crazy anymore. It doesn't sound like they don't know what they're talking about. Brain fog, their head is in a cloud. So, and that's why when I first started seeing those patients, I purposefully had them talk so that I can build my own vocabulary. And then now I use it as examples when they cannot express themselves and tell them, does that sound like what you have?
Mm-hmm. Okay, that makes sense. That's definitely something I struggle with when interviewing patients, just trying to figure out what they're actually going through. Does anyone else have any other questions for Dr. Rizk?
Dr. Rizk, I had a quick question.
Yes.
Peter Dixon here.
Yes.
I just saw 2 patients today in clinic with pure canal dehiscence syndrome, clearly both, radiographically, symptomatically, and electrophysiologically, who also clearly have a history of migraine and likely vestibular migraine. Can you comment a little bit about the link between superior canal dehiscence syndrome and vestibular migraine?
So there's not a pathophysiologic link per se, but there is a lot of overlap of symptoms, especially hypercusis. And in my experience, whenever I had a superior canal dehiscence who had a migraine history, when I operated on them, we can resolve some of their symptoms, but other symptoms persist. So now, like, I would maximally treat the migraine. Superior canal dehiscence is an elective surgery. I maximally treat the migraine, and then once this is done, okay, you still have those symptoms, we can proceed with the surgery. Or basically, so I've had patients who had dizziness that is prescribed as an imbalance, hypercusis, and pulsatile tinnitus. And they had both the canal dehiscence electrophysiologically and radiologically and had migraine headaches. And I did the middle fossa surgery. Their pulsatile tinnitus went away, but they said, but I'm still dizzy. And so again, I tease out what is the main symptom that they're struggling with, and I give them my best advice. The other thing is, I've noticed anecdotally that some of my patients with migraine have a present 4,000 hertz response on OVEMS, which is a soft marker for an electrophysiological third window, probably related to a sensitization of the pathway rather than like a central symptom rather than a true EP third window. So I'm careful when there is an overlap and a very obvious migraine disorder associated with it before I proceed with surgery. Does that answer your question?
Yeah, thanks. That's really helpful.
Awesome. Well, thank you so much, Dr. Rizk, for being on. This was an amazing talk, and we're so thankful that you came to share a little glimpse into atypical migraine with us.
Thank you. Have a good evening, everyone.